Hello, everybody. Good morning, or good afternoon, or good evening, as Guy always says. Thank you for being here. Welcome, everybody, to the second day of our meeting with the Committee on Long-Term Health and Economic Effects of Antimicrobial Resistance. And I'm going to let our chair, Dr. Guy Palmer, make some introductory comments, and then we can get started.
All right, thank you, Joanne, and good day, everyone. I guess I'll just summarize for all those in different time zones, and I really appreciate those of you for whom it's now early or even maybe later in the evening for taking some of your time outside of normal work hours to be with us. As chair of this study and of this committee meeting, I'd like to welcome all of you. The task being undertaken by the Committee of the National Academies of Science, Engineering, and Medicine is to examine the long-term medical and economic impacts of increasing antimicrobial resistance in the United States. The task being undertaken by this committee includes commenting on progress against the national strategy of combating antimicrobial resistance. And if you want more details on what that full task is, it's described on the study website. In addition, I want to note that this is an open on the record session. Interested individuals and members of the press have been invited to attend as observers, and we certainly welcome you. However, this is not a news conference, and we will not be entertaining questions from the floor. Reporters who would like to talk with committee members are encouraged to touch base with Jillian Buckley, the study director, and her contact information is present on the study website. I also want to remind everyone that this is an information gathering session only. That is that we are in the process of assembling materials that we will examine and discuss in the course of making findings, conclusions, and recommendations. Therefore, I want everyone to be mindful that the committee has made no conclusions, and it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including committee members, should not be interpreted as positions of the committee or of the National Academies. Committee members may ask probing questions in these information gathering sessions, and that may not be indicative of their personal or professional views. The committee will deliberate thoroughly before writing its draft report. Furthermore, once the draft report is written, it goes through an anonymous, rigorous review by an additional set of experts, and the committee must then respond to the review with appropriate revisions to adequately satisfy the National Academy's report review committee and the National Academy of Sciences president before it can be considered an official National Academy's report. So with that kind of as a background of just what our structure is, we're going to go ahead and begin our listening to our invited guests this morning, starting with Dr. Balachandran. So welcome everyone, and look forward to a productive meeting. And again, want to thank our speakers for their time.
Good morning and good afternoon and good evening, respected colleagues. Thanks for this opportunity. And I know that the National Academy of Sciences, Engineering, and Medicine, while you're focusing on the United States, we thought this might be a nice opportunity to also give you a very quick update on what is happening in the rest of the world. And WHO, along with FAO and OIE, have been conducting surveys quite regularly for the past 4 years, trying to understand where countries are in the implementation of their national action plans. So let me, without further ado, share my screen. One minute. There you go. I hope everyone can see the screen.
Yes, looks good.
Okay, good. So okay, So quickly, there's been a growing commitment to address AMR. In 2015, we adopted at the World Health Assembly a global action plan on addressing AMR. And this was further endorsed by the FAO and also the World Organization for Animal Health, OIE. And then the heads of state of all the UN member states issued a political declaration in 2016, really endorsing the need for addressing AMR globally. Further to that, last year, we had a very strong resolution adopted at the World Health Assembly that really focused on a couple of things. One, it focused on national action plans that countries have to start implementing and expediting the implementation of their national action plans on AMR based on the Global Action Plan, and also called on countries to more robustly monitor their efforts and report back on the efforts. So one way that we are monitoring the implementation of the national action plans globally is through the tripartite AMR country self-assessment survey. This survey is jointly developed by FAO, WHO, and OIE and administered to all of our member states. And it includes a number of components, including the key strategic objectives of the Global Action Plan, which includes raising awareness and education on AMR, strengthening surveillance of resistance, but also surveillance of consumption and use, reducing infections through infection prevention and control, water and sanitation, and also vaccinations. And lastly, also talking about the optimizing use of antimicrobials, regulations, and stewardship elements. In addition to that, the survey also tries to monitor whether countries are progressing in developing their national action plans, how are they engaging with other sectors like the animal health sector, agricultural sector, environment sector, and do they have a functioning multi-sectoral group that manages that? How are they doing with regards to legislation and regulations on the prescription, use, and also the disposal of antimicrobials? So these are some elements that are in this survey that is filled out by governments, and it's been going on for the past 4 years. And we are happy to present some results of the most recent survey. And in this most recent survey, we had 136 member states out of 194 that participated. This was a decline compared to the previous year, where we had a 82% response rate. And this year it's lower by about 10–11%. But the survey is based on a Likert scale, A to E, and levels C, D, and E suggest that the country is beginning to implement their plans at a nationwide scale and has the budget and has the financing and so on. We have also done some trend analysis looking at 115 countries, common countries that have responded for the past 3 years, so that we could start seeing some trends in the implementation of these plans. So in terms of development of national action plans, I know the United States is way ahead in this particular question. But as you can see in these slides, we are seeing and this slide suggests information from the last 3 surveys. There's been a nice shift from A towards C and D, which really connotes that most countries have moved beyond the development of their plan to actually beginning to implement and budget their plans. And I don't know whether you can see category E on this slide, but that really is the aspect that is a challenge for us globally, which is that while countries are developing their plans, and in level D, they are actually budgeting and they're working together and implementing their plans, level E really shows how many countries have plans that are fully funded. And here we really see that only 27 countries have funded their national action plans, which raises red flags. Plans are nice to have, but if they're not properly funded, they will not be implemented. The other critical aspect to note is that the vast majority of countries have really done a good job in establishing multi-sectoral working groups and are working together with other sectors. And here we can highlight that the human health sector is really working closely with the animal health sector. Almost 93% of the countries said that there is joint work between animal health and human health representatives in their multi-sectoral working groups. And the trend analysis also shows a nice increase, a 21% increase over the past 3 years in the number of countries that have established these multi-sectoral working groups. And these groups are funded, and they have regular meetings, and they're using the data to start dealing with their own country level strategies and policies. So this is quite positive that that more countries have established these multi-sectoral working groups. But this also is can be seen as a challenge, because we would like to see more than just the animal health sector collaborating with the human health sector. We need the agricultural sector engaged. We need the environmental sector engaged as well. And in these two sectors are have a lower representation in these multi-sectoral working groups. So this is something that needs to be addressed as we move forward. The next point I would like to raise is that we ask a few questions about the regulations of antimicrobials and their use in countries in the human health sector, in the animal health sector, and also in the agricultural sector. And the data looks very promising and positive. The vast majority of the countries say they do have regulations that restrict the prescription and sale of antimicrobials for human use, and also similarly for animal use. And a smaller number of countries even say that there are laws prohibiting the use of antimicrobials for growth promotion in the animal food production industry. And lastly, 75% of the countries who responded to the survey also say that they have regulations on the marketing of pesticides, including antimicrobial pesticides and fungicides, etc., that are used in farming and agriculture. But what is important to note is while the vast majority of the countries have these regulations, there is a clear disconnect in the monitoring of these regulations, of the implementation and the enforcement of these regulations. So I think many countries have taken the first step, have passed regulations and policies to address this, but I think they need more support in establishing systems now to monitor the prescription and use of antimicrobials, either in human health or for animal health, or even in the agricultural sector. So this disconnect needs to be, this gap needs to be addressed very urgently, because there's no point in having regulations if they are not enforced and monitored. Let me now call on my colleague Ponnu Padiyara to co-present the next maybe 5 or 6 slides. Ponnu?
Hello, everyone. I just wanted to echo Anand's sentiments and thank you all for the opportunity to present what we found in TRACS. So I'll be summarizing the next few slides as results from some of the TRACS indicators from the latest round, specifically focusing on indicators that are based off of the GAP objectives. So the first gap objective is on raising awareness and understanding on AMR. And here, with this question, what we've asked countries is on their participation in AMR awareness raising campaigns. And as you can see in the charts, around 44.9% or 61 of the responding countries reported having nationwide government-supported AMR awareness campaigns that targeted all relevant stakeholders, which is classified as levels D and E on this indicator. And that's what we've judged as nationwide implementation on this indicator. And in our trend analysis, we saw that there was a slight increase in this over the past few years. However, what we found also is that we asked a follow-up question on sector involvement in AMR awareness raising campaigns. And we found that around 75.7% of countries responded that human health was the main sector involved in AMR awareness raising campaigns, followed by animal health sector around 44%. But many of the other sectors, such as food safety, food production, environmental health, and plant health, were much less than 25%. And this kind of highlighted to us that this is an area that countries should strive to include more of these sectors in their messaging and outreach of national AMR awareness campaigns. Can you go to the next? So gap objective 2 focuses on strengthening surveillance. And here we're looking specifically on strengthening surveillance on AMR in human health. And around 3/4 of responding countries, so 101 of the responding countries, reported that they had national AMR surveillance activities in human health. In the chart here, those are countries that are responding levels C to E. What was interesting is that being at level C to E indicates that countries have, at the very least, national AMR surveillance activities in place for common bacterial pathogens based on national standards, along with the National Reference Laboratory and external quality assurance. However, what was interesting was that while 101 countries responded that they have these national AMR surveillance activities, only 92 countries were enrolled in WHO's global AMR surveillance system, and only 66 countries were providing resistance data to class. We think this could be because there are countries that provide data regionally and maybe not globally. In a related tracks question that we asked, we also found that around 64.7% of countries responded that they do amend their national AMR strategy for human health based on relevant AMR and antimicrobial consumption data, which is a good sign. And it's an example of the data-driven decision-making that we would like to continue to see from countries. Next. We also looked on strengthening surveillance on AMR in animal health and food sectors, and the distribution for both of these sectors and countries were very similar. There was a similar percentage of countries that reported that they collect at least some AMR data in animal health and food sectors. That again, here is represented by levels C to E. It's both around 69%, both in animal health and food sector. So around 69% of reporting countries fall in those areas. And the trend analysis here also is slightly encouraging. It does show a gradual increase in national AMR surveillance activities over the past 2 years. It shows around a 10% increase. Next slide. A part of gap objective 2 is not just strengthening surveillance of resistance, but also strengthening surveillance of antimicrobial consumption, both in the animal health and the human health sectors. And something interesting that we found is that there are more countries that have responded that they've developed national monitoring systems for antimicrobial sale and use in animal health compared to human health. So around 63.4% of responding countries have monitoring systems in animal health compared to 56.3% in human health. And one of the reasons for this, we believe it could be because monitoring systems for antimicrobial consumption for animal health could have been set up earlier, potentially due to trade incentives that existed. This was also one of the indicators where we did have external data that we were using to validate the self-response. We did find a discrepancy between the consumption and use numbers that are submitted to tracks, and OIE's data on antimicrobial use in animals that's submitted to OIE by their member states. This sort of highlights a need for stronger multi-sectoral coordination in countries. That's a warning to us that there needs to be a stronger multi-sectoral coordination, because there might be data that exists in a country or within a sector in a country that is not being shared with the multi-sectoral group that's working on AMR implementation in the country or submitting data to tracks. Next. GAP Objective 3, as Anand mentioned earlier, it focuses on reducing infections. And this indicator was specifically looking at reducing infections through IPC in human health. And less than 40% of countries reported having nationwide implementation of their national IPC plans. These are plans that are supposed to be developed based on WHO's core IPC guidelines. The response here is levels D to E. That's what we counted for this indicator as nationwide implementation. And the trend analysis does show an increase, at least compared to last year, but 40% of countries at nationwide implementation is still not quite the target that we would want to see globally. However, most countries, the most common response, as you can see, is level C, which is that they have the national IPC plans ready and developed, but it's just not implemented nationwide. It just has limited implementation in certain healthcare facilities. So those are countries that from a global perspective, we would want to focus on to see what additional ways we can support them to move them up certain levels. The Objective 4 of GAP focuses on optimizing use of antimicrobials. And here we're looking at specifically policies to optimize use of antimicrobials in human health. And of the responding countries, around 70%, a bit higher than 70%, responded that they fell within levels C to E, which is that they had practices or policies to ensure appropriate antimicrobial use is being implemented in at least some healthcare facilities, and that they also had guidelines for appropriate use available for prescribers. However, what's surprising is that even though there are, over 70%, a bit more than 70% of countries that fall in C to E, there's only 6 countries that are at level E, which is characterized as countries that have antibiotic prescribing guidelines for major syndromes, and countries which send antimicrobial use data back to prescribers. And that's an intervention that we've seen in some countries that, can lead to a decrease in overprescription of antimicrobials. Lastly, this is the first year that we asked this indicator, which is the adoption of the AWARE classification of antibiotics into the National Essential Medicines List. AWARE is a new WHO tool that classifies antibiotics into 3 stewardship groups: access, watch, and reserve. Access is first or second line choice of antibiotics. Watch are a lot of the antibiotics that are reserved or shown in the critically important list. And reserve antibiotics are the last resort antibiotics. Countries can use AWARE or adopt AWARE into their National Essential Medicines List or National EML to guide antimicrobial stewardship activities. And we've seen evidence that shows that in order to optimize the use of antibiotics and reduce resistance, countries should increase the proportion of access antibiotics to correspond to at least 60% of total national consumption. So that's kind of the target that WHO has set for that nationally. And based on the global response, we see, it's only around 34 countries right now that have reported that they've adopted AWARE into their National Essential Medicines List. But we see that around 60% of the responding countries are at level B, which means that they have knowledge of the AWARE classification and that they plan to adopt it over the next few years. So this is an indicator that we would want to track very closely over the next few tracks rounds to ensure that we do see movement from level B to level C for many countries. At this point, I'd like to hand it back to Anand to kind of give a summary of everything that we found through all of our analysis.
Thank you. Thank you, Panu, for going through those slides and the data. It was very helpful. So overall, in terms of the findings from this recent survey, I think we should be pleased that more countries are taking AMR and their national action plans more seriously, and they are at levels where they are beginning to implement and beginning to fund their national action plans. Secondly, there are many more countries that have established functional multi-sectoral working groups, and I think this is a positive sign. But more work needs to be done. But just the fact that they are getting together, they are meeting regularly, across sectors to discuss AMR, I think it's positive. That's positive news, and that needs to be highlighted. Thirdly, I think it is useful to note that more countries are now beginning to implement their infection and prevention and control programs nationwide, and I think this is positive. Even though the number is small, I think it is positive news given the very low levels they were at 3 years ago. So in terms of overall trend analysis, the past 3 years, we are seeing an improvement in the level of awareness of AMR, and campaigns being conducted nationwide to promote and to increase awareness about AMR, and also training. I think education and training, pre-service and in-service training. I think this is something that is quite positive, and we need to further encourage this training and awareness raising across all sectors, not just the human health sector. The second big element in terms of the trend analysis is that we are seeing more countries establishing monitoring systems for monitoring resistance, but also consumption and use. Again, I think we have quite a ways to go, but I think for many of these countries who have significant other challenges to deal with, I think this is positive that they are establishing these systems now slowly. And we are hoping it might take another 3 to 5 years for them to start producing significant data, including data that is linked to the SDG's new AMR goal, which is I think 3D2, which is specifically linked to AMR surveillance and bloodstream infections. So lastly, in terms of areas where we think additional efforts are needed, and here I think WHO, FAO, and OIE are all quite aligned, and we are all saying that we need strengthening of the multi-sectoral coordination and collaboration. This whole One Health approach needs to be further strengthened. It's a nice, easy slogan, but making it work at the country level across different ministries, different sectors with different competing interests is very, very difficult and challenging. So we need to continue to work on this. Secondly, we need to further highlight the need for more targeted AMR awareness and education campaigns, not just in the human health sector, but also in the food production, food safety sectors, animal health sector, and the environmental sector as well. Thirdly, we do think that there needs to be a further increased focus in the monitoring and enforcement of regulations and legislation on antimicrobials, their prescription, their use, and their disposal. So we think there's no point in just having regulations. Countries need to move to the next step of monitoring and enforcement. Fourthly, this is more in the human health sector. There is a strong need, while all of us are concerned about misuse of antibiotics and overuse. In many countries, there is significant lack of access to the most basic antibiotics. And not just basic antibiotics, but quality and safe antibiotics. So I think there's a need to strengthen access to essential antimicrobials using the aware framework, and also using that as an opportunity to reduce the consumption of the watch and reserve categories and increase the proportion of the access group of antibiotics. Lastly, and this is a need from all of our regions and countries, they want more technical capacity. They want support from external partners, donor countries to strengthen their technical capacities for example, for surveillance, for lab strengthening, for establishing monitoring systems for consumption, and also for monitoring and reporting on data. I think they are all at a stage where they are establishing their plans and starting to implement their plans, but they all feel that they need stronger technical capacity in the countries and also stronger monitoring systems in the countries. So I think those were the overall summary messages. And again, on behalf of colleagues at WHO and FAO and OIE, I would like to thank you for this opportunity. And almost all the data that we presented today can be found in this website, www.amrcountryprogress.org. Thank you very much.
Thank you. Thanks to both of you. And do want to emphasize, even though our statement of task does describe the National Action Plan for the United States, is that there's really three global components. One, obviously, this is a global problem. No country is an island in terms of AMR. Second is we want to collaborate and learn from the international agencies and their efforts, as you have pointed out today, and also learn from other countries what has worked and what has not worked to strengthen ours as well as other national action plans. We have just a couple of minutes for questions, as in two, but for those questions I don't get to, we will get those written down and see if we can either come back to them later in the session to address or ask them to you through email. So I'm just going to go in the order of the questions asked. Andy, why don't you ask your question, and we'll see if we have time after that for some of the others.
Yeah, thank you so much for sharing these insights at the global level. A very basic question, which is, are results available by region and or country? Because I think in that manner, it would help better understand, how to target, just generally speaking, targeting support, resources, training, etc. Thank you.
Yes, if you go to the website, you can look at results broken down by specific countries and regions, and even by income groups. So there are multiple ways you could look at the data.
Thank you.
I suppose we have time for maybe one more question, and I'm so sorry for those that we're not getting to, but we have a question about the precise definition of national implementation plan, national implementation of IPC plans. For example, is the United States one of the countries considered to have a national implementation of IPC plan?
Yeah, so I can take this one on if that's okay.
Please.
So the precise definition is essentially what we're looking for here is if a country has, sorry, one second, is if a country has a national IPC plan or program that's based off of WHO's kind of recommended core IPC guidelines. And they include, there's like 8 core components relevant to IPC programs, such as evidence-based guidelines, education and training, healthcare associated infection surveillance, and several others. And if a country has a national IPC plan, that's great. But what we also want to see is that in most of their healthcare facilities nationwide, and not just maybe in a certain city or a certain area, that they have implemented these plans. And US generally, yes, for the past few years has always responded E, which is the highest level. So that's the level that the US has been over the past few years.
Okay, well, thank you. I wish we had more time, and hopefully we can come back and revisit some questions at the end of the session. So I think our next speaker is Dr. Simonson. So could you stop sharing screen? I think that would.
Yes. Can you hear me first?
Yes.
Hear me, and maybe you can see my slides now. Can you see them?
Perfect. Yes.
Okay, all set. So thank you. My name is Gunnar Skov Simonsen. I'm talking to you from Norway, from far up in the north. And I'm very happy to attend this session. It was very interesting to hear from representatives of the WHO. Before I start talking about this very strange place in terms of AMR in Norway, I just need to emphasize that we actually do engage in the rest of the world. I was working at WHO for a year when the first Global Action Plan was issued in 2002, which was unfortunately not very successful. And also, I've spent quite a lot of time assessing or auditing other European countries, and also working in Malawi and Mozambique. So we fully acknowledge that Norway is a very strange place when it comes to antibiotic resistance. But I hope maybe some of our experiences would be of some interest to you. I'm a clinical microbiologist, and I'm in charge of the Norwegian surveillance program. And presently, this invitation came at a very nice time, because we are actually renewing our strategic national plan in Norway as well now. So in addition to talking about how we've developed and worked with the present strategic national plan, I'll also give some views on where we are heading for the next 5-year period. So let me see. This first slide is just to really make you understand that the situation we have in Norway is actually quite different from what you have in most other countries. These are the maps from the European surveillance program, the EARSnet, and as you can see, Norway pretty much ends up in the green end of the map, together with other Scandinavian countries, and often with the Netherlands as well. The exception being ESBL E. coli, where we have actually crossed the 5% mark. It's not very high in a global perspective, but for us, that signifies that we actually do have some resistance problems in our country as well. The present strategic plan we have in Norway was issued in 2015, but it's very important to realize that that was actually the third national strategy, with the first being issued in the year 2000. So for the first couple of plans, we did a lot of work on developing the tools needed to deal with AMR. So in the upper left corner, you have the traditional curves you can see, all graphs you can see for AMR here, ESBL, E. coli, and Klebsiella, separated in blood and in urine. And you can see these trend lines, which many countries can produce. In the upper right corner, we have the consumption data. We have a very extensive registry for prescription of drugs. We have both gross consumption from as procurement data, but we actually also have a prescription database down to the individual prescriber and the individual patient. So we know actually quite a lot about how antibiotics are used in our country, and that's of course a very core component of our strategy when trying to influence antibiotic prescription, is that we know a lot about how antibiotics are prescribed and by whom. Lower right corner is that a number of multi-resistant microbes are subjected to notification. So we have individual notification of MRSA and CRE and VRE and a number of other of these most problematic phenotypes, with the consequence that we have quite detailed knowledge about how the epidemiology evolves. This kind of notification system is, of course, a consequence of our very low resistance rates. You cannot have that level of surveillance in a country where we have much higher resistance rates. But in Norway, as of yet, we can still pretty much track a lot of these microbes as they enter the country. Finally, down at the lower left corner, we have a number of reference laboratories which will do yearly surveys. They will do whole genome sequencing on all these very resource demanding analyses which help us to understand what's going on. Okay. I tried to figure out or define the guiding principles for Norwegian strategy. And first of all, we are, of course, very much attuned to the One Health principle. However, I do want to emphasize that AMR is not only a One Health issue, in the sense that there are many aspects of the AMR situation which should not be kind of put into the One Health box and seen as a sort of a link to agriculture and environment, because we have some very specific human health issues related to hospitals and also, of course, pathogens which only are transmitted among humans. Gonococci, pneumococci, tuberculosis, and so on and so forth. So we try to kind of keep those two thoughts in our head at the same time. We have a very strong focus on an intersectoral approach, and we do share data, we do produce joint reports, and we have regular meetings where we meet all of us. It's a small country, so we can meet people from human health, those who write the treatment guidelines, as well as the veterinarians, the people working on IPC, and people more on the GP level. And in a way, we try to kind of bring together all the different stakeholders. Secondly, engagement across society is an interesting aspect, because as you know, we are neighbors to the Swedes, who are always been sort of the international champions of how to organize AMR strategies, and they have for many years they had this very strong focus on the Strama model, which is a model based on almost a separate agency in charge of AMR, with some kind of ability to influence both healthcare and agricultural and environmental aspects. In Norway, we very early decided that we did not want to go in that direction, because we wanted to make all different agencies and stakeholders responsible for taking part of this. We felt that if we had this as a very separate entity, we would lose the kind of the cross-sectorial responsibility for it. It would be kind of sectioned off. And as a consequence of that also, you have this issue of budgeting. Always when we travel to other countries, we ask people, do you have a separate budget? At the same time, I realized that back in Norway, we actually do not have a separate budget for a lot of the activities we do in terms of AMR, because we have different means of in a way, encouraging and forcing the different players in this puzzle how to take their responsibility, instead of kind of putting a pot of money in one end of the government. Accountability. This again comes down to everybody from the farmer industry to the healthcare providers to the GP on the corner, and of course the pharmaceutical industry. Everybody is kind of pulled into this overarching strategy and held accountable. Transparency is very important. We share a lot of data, we publicize a lot of data. We put out data about the AMR consumption, antibiotic consumption and AMR rates for hospitals by name. So it's not a shaming, blaming mechanism, but we do believe in having a very transparent flow of data. What was new, very important in the present strategy, was that this policy of setting very specific targets. And I'll come back to that, but to a large extent, the strategy is focused on reducing antibiotic consumption, and by specified numbers, different areas we wanted to achieve reduction of consumption, and I'll show it to you. And of course, I mentioned already stakeholder involvement. In Norway, health services are all hospitals are public, so it's much easier than in countries where you have a large private health industry. But of course, in agriculture, we have the same aspects of the need to engage also private industries and private stakeholders. And I think for many different reasons that has been quite successful. Okay, you can see here the national strategy. It's we actually have published an English version. You can download it from the internet. And I will not go into all the details of it because it's quite comprehensive. But the overarching goals for the period 2015 to 20 is to reduce the total use of antibiotics, to encourage more appropriate use of antibiotics, to improve our knowledge about the drivers, and of course, to be a driver in international and normative work to improve access, responsible use, and development of new antibiotics, vaccines, and better diagnostics. The problem when developing these strategies in a very low AMR country is not really to define the overarching goals, because that's kind of page one. You know, the initial part of all national strategies are pretty much the same. The difficult part is how to formulate specific targets and what you want to do more specifically, which is achievable and relevant for the situation in that specific country. I'll come back to the discussions we've had about how to do that in a country where the situation is pretty good in many ways. A lot of the focus is on trying to preserve the situation as it is. Of course, to have a very strong overarching mandate is important. And here you can see the main specific targets sorted by the ministries responsible for them. So, of course, the Ministry of Health and Care Services is important. And there you have a number of very specific targets, which I will come back to, several of them. Equally, the Ministry of Agriculture and Food has got a number of relevant targets. And then we have some, you could say, well, not less important, but ministries where they have, they allocate less resources and they have less ongoing duties or related to the strategy. But nonetheless, both the Ministry of Trade, Industry and Fisheries is important. Of course, we have a huge aquaculture industry, which I will also come back to. And then we have the Ministry of Climate and Environment, where we have this, the third component of the One Health strategy. It is very important to have a kind of a mandate at the very highest level, because you always run the risk of being running back and forth between agriculture and environment and health, and then everybody will kind of say, well, it's some of the other ones who have the main responsibility here and who really should change. So at the ministry level, you have a group of senior officials within the ministries who meet on a regular basis to coordinate and see to it that they actually follow up on the specific points. So that's a level above the kind of the technical level where you have all the experts coming in. So this is more like a kind of the interface between the central administration of the government and the political level. So, and I think that's a success factor to actually have this, this level. Okay, if we look a little bit about the data, I will not show you too much because it's hard to remember, but one of our goals was that we wanted a reduction of 20% in the total antibiotic usage in humans by 2020 compared to 2012. So the metrics were quite easy because we can measure our antibiotic use in all these different ways. And sorry, I misspelled it. It should be 30% reduction. It should be a 30% reduction, and we are almost there. We don't really know how things will play out now by 2020 because of the COVID and all these things which are happening. But I think by and large, we have come pretty far in this with this target. And the way it has been done, this, of course, to a large extent is about what goes on in primary care, because that's where the largest volume is found. And we use this prescription registry to actually give feedback to all primary care doctors in Norway about their prescription profile, so they can see what is actually their prescription profile, and it is compared to their peers. So in the same area, they have these municipalities. They can see whether they are kind of on track with the other ones, or they are an outlier in terms of how much and what kind of antibiotics they prescribe. And they all have these colleague groups where they kind of compare and work together on it's sort of a system for continuous medical education, and there they use these data to compare and discuss best practices. It's not a kind of a censoring of how they prescribe, but it has had a very strong influence as they progress. Similarly, in the hospital sector, we wanted a reduction of broad spectrum antibiotics, and you can see to the right, you can see the antibiotic groups or classes we have defined, which will be the quinolones, the carbapenems, the second and third generation cephalosporins, and then the combination penicillins with a beta-lactamase inhibitor. In Norway, that is actually, to a large extent, piperacillin tazobactam, because amoxicillin clavulanic acid has only recently been introduced to the Norwegian market. Also here, we wanted a substantial reduction. We have not really reached it yet. We are a little bit lagging behind, but I think we'll get there. We will probably need a year or two extra in order to reach our target of reduction here. If we look at the animal side, the goal was to have a 10% reduction overall in production animals. They started out their action plan based on 2013 data, and it's a little bit complicated, the figure, because on the left it's raw metrics in kilogram. On the right we use the milligram per production correction unit, which is a more sensible way of correcting for the animal population, actually. But as you can see, there has been a nice reduction, and already by 2017 we were approaching the goal, and for the last 2 years we have actually been there. This is a consequence, to a large extent, of a close collaboration between the veterinary institute, the veterinary public health authorities, food safety, and of course the farmers' organizations and the people working out in the field. If we look at aquaculture, I just want to show you this figure. It's a reminder that back in the 80s, when aquaculture became a huge industry in Norway, we in number of kilos or tons of antibiotics used in Norway, in the late 1980s, we approached the same amount of antibiotics for salmon as we did for humans in the country. So we quickly realized we have a huge problem here. And by the mid-1990s, this consumption had been reduced to practically zero, which it still is. The green line here is the amount of produce, the amount of farmed fish we produce. So the solution here is, of course, the introduction of a number of vaccines for the bacterial infections. So the use of antibiotics for aquaculture in Norway has practically been abolished. The target here is, you could say, it's not very ambitious, because it only says that we want antibiotic usage in aquaculture to be below the 10-year average in the previous decade, and we've been there. It goes a little bit up and down, but that relates to the fact that the consumption is so low that individual fish farms being treated with antibiotics will actually make a huge difference in these graphs. We also have an issue with this, what we call sports and companion animals. And here again, 30% reduction over the period from 2013 to 2020. And it has been achieved over the last 2 years. So for the veterinarian side, one could argue that the targets may not have been ambitious enough. On the other hand, if we look at the long-term trends, they have improved substantially from a very low level. And that's the same if you compare us to, in the human health side, to other European countries and countries around the world, that a substantial reduction has been achieved, even if we were at a fairly low level from the beginning. About the environment, then the third component, that is definitely the area where we've not made the same progress. But what we have done is that we've made a number of these sort of assessments or surveys. And you can see here one on red foxes, one on deer, one on reindeer, and one of seafood, clams, and so on. So we've had funded a number of projects to look into specific areas of wildlife and environment. But I think it's fair to say that we have not really reached a conclusion as to how we should monitor or perform surveillance in the environmental context. It takes a lot of resources, and it's very hard to kind of make a good call on what the results mean. Finally, to bring it all together, we have these risk assessments, and that is because especially microbiologists, they have this propensity to find resistance everywhere they look. And then you have the question, well, what does it really mean? Does this represent a risk? Is it more like a theoretical problem, or is it something we need to take action in terms of either monitoring or maybe even issuing regulations? So we are still trying to refine our way of interpreting our data in order to make most sense of the data we have collected. I mentioned that we're actually at the end of our period now, our 5-year period. So 2020, the 2020 deadline has been extended until 2021. But we are presently working in a kind of an expert group to put together an assessment of where we stand, what we are lacking, and where we are heading for the next strategy. The government has clearly stated that they want a new national strategy. And I think our challenge here in many ways is that if you look at the standard national strategy, the core components will often be linked to surveillance, to guidance, to regulation to ensure prescription only use of antibiotics, and so on and so forth. In many ways, all those components are already in place, but we still feel a bit, we're still worried about increasing rates of ESBL. We still have these issues with CRE being imported and in some instances even locally spread. We do have a national action plan specifically on IPC in hospitals, which is being rolled out in these years. So we feel that we need to make an assessment of where we stand, and in many areas we actually need to invest more in research and of course development of new diagnostics and antibiotics is one side of it, but also to make good cost analysis of what these different initiatives may cost and what we will get out of them, because we feel that together with the other Scandinavian countries and the Netherlands, with these very low rates of resistance and this very prudent use of antibiotics, we need to figure out what should be the road ahead. So with that, I think I've got 5 minutes left, and I'll be happy to take any questions.
Thank you so much for that presentation. That was really helpful. And just in the interest of time, I have some questions that people have already sent in the chat. So I'm just going to start with those. One is, can you talk about ways to incentivize the rapid development of vaccines for emerging diseases? This is from Marta Gomez-Chiari. She says, assuming that the spike in the use of antibiotics is due to new outbreaks, and particularly, she brought this up relevant to aquaculture.
Yeah, well, I think it's fair to say that in aquaculture, the drive to achieve these successes with vaccines was a kind of a combination of market-driven and regulation-driven efforts. Clearly, Norway at that stage saw huge opportunities in aquaculture, but we felt really bad about kind of putting all these environmental toxins into the sea. So and also the industry knew that if they want, one of their main selling points, and that also goes for the agriculture side. One of the main selling points is that it's actually quite healthy. What the product is healthy, and it's based on environmentally sound principles. So they were very interested in it. From a regulatory point of view, they took action and said that this practice must change. And of course, academia was very much engaged, and even or especially our university up here in Tromsø had some very active groups. And then it turned out that they were. I mean, vaccine development is not just that's not an easy area, but they were lucky. They quite rapidly found good antigens and good targets for their efforts. So I think a combination is important, but we are still also in human health. We are discussing. We don't really have. We have, of course, a childhood vaccination program in Norway for humans. We don't really have that for the adults and the elderly, and that is one of the things we are discussing in the new strategy, whether we should actually have a public adult vaccination program to ensure widespread influenza, pneumococcal vaccination, these things which can further reduce the demand side for antibiotics.
In case, I'm not sure if I have several questions here, so I'll just hit another one. Gunnar, you were asked to give a little bit more detail regarding how you monitor MDRs as they come in. You mentioned that was part of your approach, and the questioner is wondering, as our committee member is wondering, how that's done and how that monitoring controls spread.
Well, the easy part is if you enter a Norwegian hospital, or you are transferred from health services outside Norway into a Norwegian hospital, you're screened for MRSA, VRE, ESBL, CRE, and what have you. So that is kind of the easy part if you're a defined patient coming in. The difficult part is, of course, all these healthy people who travel around. And of course, we do not have a kind of a border control on that. But we do emphasize and inform all participants or stakeholders in the health service that everybody who enters healthcare, and especially, of course, acute care hospitals, they will be asked whether they have been abroad, and especially, of course, in these highly endemic countries, and even more if they have been in contact with health services. And that will again lead to isolation and screening until they are cleared. And of course, it takes a lot of effort. It was all established during the 90s due to the MRSA epidemic, but we have more or less continued that with the surge of the gram-negatives.
Okay. I think, let me see. Okay, but I think we can squeeze in this last question. And our committee member was asking if, again, in aquaculture, do you see similar gains in growth and low mortality when using vaccines as a farmer would with antibiotics? Asking, what does the economic analysis show relative to cost? And this is again with the aquaculture.
Yeah, I think I will answer that question for aquaculture and agriculture combined. And that is that in a Norwegian context, we see no economic benefits of using antibiotics for growth promotion or a kind of a blanket treatment whatsoever. To the extent, the general perception is that if you have negative economic impacts of your industry from not using antibiotics, that is a consequence of inferior infection control practices. So that's a very harsh statement, and I know it's very difficult to achieve those goals. But I just refer to it the way the Norwegian veterinarians will tell you that, of course, they use antibiotics, but extensive use of antibiotics, be it for fish or for for beef production or for pig production or poultry, that can be resolved by simply focusing on infection control practices.
Okay. Well, I'd like to thank you so much for that presentation, Dr. Simonson. That was extremely helpful. And, you know, we have 10 minutes now to take a brief break and then reconvene. And will you be around for questions again at the end of the session?
Well, I'm sorry, but I'm on call for the COVID
Of course.
situation.
Yeah.
But,
Thank you anyway, though.
Okay, thank you for having me.
All right.
Bye.
Bye-bye. Okay, everybody, thank you. Thank you for getting back with us. It looks like we are welcoming people back from break. I'm not sure if, okay, Guy, I see you have your microphone off, so I'll just be happy to introduce your colleague, Dr. Arestrup. Please correct me if I pronounce that wrong, presenting about antibiotic resistance in the food chain. So thank you for being here, sir. And you can go ahead and share your screen if that is working for you.
Yeah. So this is Frank speaking. Can all of you see my screen?
Yeah, very good. Very well.
Excellent. And thank you for inviting me. And I also hope you can hear me, of course. But I was asked to talk a little bit about antibiotic in the food chain. And it's certainly something that I have been working on for, well, I tried to work on at least for 25 years. And it's a little bit striking still that, the limited amount of really hard rock evidence rock solid evidence we have, even over such a long time. But I also think that I might come into, okay, what is the reasoning behind this, and what can we potentially do about this? My name is Frank Arestrup. I'm from the Technical University of Denmark, and I'm also heading the EU, WSO, and FAO reference laboratories for antimicrobial resistance. I think that when we talk about the importance of the food, animal food reservoir for human health, it is something that very, very easily can raise people's temper. And we also get a large number of different estimates. So anything ranging from, okay, it actually means absolutely nothing, or to it's thousands of people dying every year, and a lot of diseases are all around the world. And I guess that depending on where you're looking at it from, they might actually all of them be right. But I think that also just logically saying that the animal reservoir means nothing makes no sense. But on the other side, of course, that it's the overall importance and it's the scapegoat for everything doesn't make sense either. So it's probably not the truth, is somewhere in between. I think when I first started really working with antimicrobial resistance, and that was when we collaborated with the World Health Organization around the year 2000, this was a little bit like, the way we saw the world regarding antimicrobial resistance. There were some resistance problems that were confined at hospitals. That was, like Pseudomonas aeruginosa, Acinetobacter, something that might be in the community, but still only exclusively in humans, like Streptococci and influenza. And then there was the zoonotic bacteria, like, Campylobacter and Salmonella, where they were selected by use of antimicrobial agents in the food producing animals, transmitted through the food chain to humans and causing problems. So all, the zoonotic resistance was caused by, selection in the animal reservoir. And then there was we were a little bit in doubts about, okay, could there be something about resistant E. coli, the vancomycin resistant enterococci, and perhaps some of the resistant Staphylococcus aureus, maybe. Now, 20 years later, it's a little bit more difficult because there's also other bacteria that's come into play saying, oh, but doesn't these bacteria, also have an animal reservoir? What about Clostridium difficile? What about all these MRSA, livestock-associated MRSA? And then the big unknown, all these, mobile elements that are jumping around, from one bacteria to the other. So basically painting the picture that emergence of a mobile element somewhere in India, whatever, 10 years ago could actually be the cause of infection in the US today, but it's very difficult to trace that back. And I think that today, after working with this in 20 years, I think that, well, there's a lot of things, or actually more things I would say that we do not know than we do know as of today. In Denmark, we have tried to follow what is happening within our own country rather intensive over time. And we've also been quite fortunate, especially during the 90s, that we had some major interventions where some things were happening and we could follow the consequences of this. And this slide shows the antimicrobial consumption over time in Denmark from back in 1994. The dark bar here, that is the use of antimicrobial agents for growth promotion, something that is not longer allowed in the European Union. And then the Turkish one here, that is the consumption or the use for therapy. And this is adjusted to, the millions of pig produced, or the milligram antibiotic used per kilogram pig produced. And then this one line here, the red one, that is, how much pig produced. So we have had an increased pig production over time. And then some of these interventions that were actually able to show, okay, what then has happened to resistance. And I think that no matter where we have looked, where we have really made drastic interventions, and I'm talking about drastic interventions because just changing the consumption with 10%, at least reducing it with 10% or something like that, that is not something we can see when we go out and look at it national-wide. But if we really remove 50 to 100% of a compound from a reservoir, we can actually see in all cases a decrease in resistance. And that doesn't matter whether we're talking about Campylobacter coli, Escherichia coli, Enterococci, it is all around the place. One of the problems, especially in the 90s, was that we had very good monitoring on the animal side, but unfortunately not at that time any good Danish monitoring of what was happening on the human side. So we couldn't really link, the interventions on the changes on the livestock side with see where anything was happening on the human side. Always unfortunate when you do not have good monitoring at both sides. So there was another example, and I think it's really an excellent one, that is from Canada, where in 2004, they convinced the farmers to go out and stop the use of third generation cephalosporins or the Cephalosporin, and then they were able to follow what happens in terms of resistance among Salmonella in both retail chicken as well as in humans. So really they had monitoring on both sides going on simultaneously. And as you can see very, very, very nicely, there's an intervention and then you have a reduction in resistance, not only in the retail, but also in humans. So once again, proving that the zoonotic link and the zoonotic transmission. There's also a decrease in resistance in E. coli. So once again, proving if you really make drastic intervention, you can reduce resistance. In Denmark, we have also looked, of course, into our broiler production. And then, strangely enough, from 2009, 2010, and 2011, we saw a major significant increase in third generation cephalosporin resistance E. coli among broiler meats. And that was completely unexplainable for us because, well, we had never used third generation cephalosporins for chicken in Denmark. So there was no selective pressure. And even other antibiotics that could co-select with the usage was extremely low. The consumption of antimicrobial agents in the Danish broiler production is actually extremely low, and still is. We're talking about very few kilograms of uses per year, and we produce more than 120 million broilers a year. But we were actually quite happy then, because then we thought, oh, what is happening? And I guess you need to be born in Scandinavia to be able to see the relevance of this story. But remember, in Denmark has been at war with Sweden for so many years, and basically for the last 400 years, we have lost any war we've been fighting against the Swedes. So we were extremely happy when we were able to see, oh, we can blame it on the Swedes, because we are actually buying, the parent flocks from the stock from Sweden, and we try to look at now we can blame the Swedish community that they are actually the cause of these problems in Denmark. But they immediately responded that that's not true, because it's actually originally comes from the UK, so it's all the blame on the United Kingdom. So unfortunately, we could not longer blame the Swedes. But I think that for us, it just shows once again that when it comes to food transmission and the food to animal reservoir, it is really a problem in one country, it's a problem in all countries. And we can also see that in some cases you have special products you're raising within your country, but then are selling it in another country. So it's not really impacting you or your community. So, and if you want to investigate this, you really need to have the simultaneous monitoring going on in all these reservoirs and in all these countries. So it brings me to why is it that it is so difficult to prove and also to quantify the importance of the food animal reservoir. But basically, we do actually have extremely few examples where antimicrobial agents are exclusively used for animals. And in most cases, the consumption started in humans first. There are some examples like streptozotocin, promycin in Europe, where you say that aminoglycoside antibiotics that are only used in animals, and we can see that it's selected for, and we also see these resistant genes that spill over in the human reservoir. But since it's of no importance for human health, people are not really looking at it, or at least the medical doctors are not really looking at it. There's, of course, around the world, some human monitoring of resistance, but still a very, very limited animal reservoir monitoring of what is going on. And I really think that we need this, long-term comparable surveillance data of all potential reservoirs if we really want to get at the angle of this. And I think that's illustrate, at least attempt to illustrate this on this slide. And I know it's a very lengthy slide, so I'll also go to run through it. And I think that this is probably also a chain of events that likely happens for most infectious disease agents, not only antimicrobial resistance, but a lot of bacteria, a lot of viruses, including, of course, something like the current coronavirus we're seeing right now. That in most cases, we have some kind of activity going on in all the animal reservoirs we have around the world. That could be wildlife, but it could, of course, also be the livestock reservoir. And then from time to time, there is a spillover into the human reservoir. And once in the human reservoir, well, most of us carry something in our guts. And I'm definitely sure that most of you and me as well are carrying antimicrobial resistance in my gut, and it has come from somewhere. But I consider myself rather healthy, at least right now, and it's not actually not cause a problem. But it could be that 2-3 years from now, I could be sick by something that I'm colonized with now, or someone else could. And then I might experience symptoms, I might be sick, I might go to the doctor, I might actually eventually be diagnosed, especially if I'm in a developed, a country, not a low middle income country where the diagnostics or the surveillance capacity is not so good. And then if something is wrong and I need treatment, I'll go on a first line drug. If it doesn't work, I might get on a second and last line drug. And then it might actually, be of interest for the scientists, for the medical community, because then we're looking at the last resort antimicrobial agents. And there's a very, very, very long line of evolution and emergence and transmission from something happening in the animal or the livestock reservoir, and then eventually actually creating, interest in the human medical community. And as we all know, most interest, most focus, most research is really on the last resort antimicrobial agents, the critical sick, whereas there's very, very, very limited to those that are really used in large amounts around the world. So it's difficult to trace back once you ended up in there, and visually there's no way you can trace it back because we cannot really ask the genes where they have been some years ago. So we have been some examples of people actually then saying, okay, let's jump to mathematical modeling then, because if we do not have the data, at least we can build the models. And there's a lot of models, there's a lot of reviews out there, so I a little bit will actually be careful to highlight some. But for me, some of the two models that I have read, which I think the most interest at least, is this one from, if I remember correctly, from a 2003 in a PNAS. So actually from Proceedings of the National Academy of Science, it's I think it's good. And it basically just a model showing that if you have selection in the animal reservoir, as soon as you actually have the spillover to the human reservoir, then the animal reservoir becomes of less and less importance. And then the other one that's a little bit more recent, where they show that if they, after spillover, simply stop using antimicrobial agents in the animal reservoir, then it has very, very, very limited importance. And I think that it's probably illustrated something like this, that if you look at antimicrobial resistance in livestock versus humans, well, you could have this event in the livestock. At some point in time, something is being transmitted to humans, and then you have an independent emergence and selection in the human reservoir. And then even if the livestock reservoir disappears, well, the resistance will still be there in the human reservoir. It could be that the origin of all this was the animal reservoir, But if you're standing here, and this is often where we start looking after the problems, well, there's nothing to detect out in the animal reservoir. You're basically doing the monitoring in the animal reservoir, too late to do anything. So at least in my own personal humble opinion, what the world needs is really longitudinal, long-term, real-time data on occurrence of all infectious agents everywhere, preferably also antimicrobial resistance. All geographic, all reservoirs, and all around the world. There is, of course, a few issues to solve there, but I think if people just share the data and start doing it, I think that it is actually something we can solve. We have ourselves been focusing a lot on all the advantages around next generation sequencing. I think a lot of you have as well. And I think that's well, the most important thing for me is that it basically provides a universal language that would enable us to capture surveillance data in a standardized way, and then also share it and reanalyze it. In the year 2000, we were trying to start to do some surveillance of antimicrobial resistance in Salmonella for the World Health Organization. It took forever because we were getting, reports from different countries in different spreadsheets and formats, and they all submitted this in their own national language. So I've been receiving something, in Thai, in German, in French, and I do not speak any of these languages. So it's impossible to guess what's there. And then also, I counted that people actually were capable of spelling Salmonella in 50 different ways. I couldn't do that if I tried. So, but NGS data is, universal language automatically. There's no human errors, and it's just 4 letters. So it's quite easy. So we've been focusing a lot, and I know there's unfortunately also something like FDA and CDC in the US has also been focusing a lot on, is it actually possible to get away from this classical, traditional science where it's just about getting samples and analyzing and publications, and then actually a little bit more about, okay, could we start sharing data around the world and then collaborate? So sharing all the information and doing something around that. We have, of course, been working on single isolates, just as so many other has. I do think that it is still an issue with sharing of the data, especially from the human reservoirs. I think that it would be nice if we could get more sharing from, the hospital laboratories. I think that's a major challenge still. I think that, the Food and Drug Administration are good at sharing their data. Also the Center for Diseases, at least when it comes to the foodborne arena. But outside that, it would really be nice if the human medical community could also a little bit, sorry for language, get their act together and start sharing a little bit more about what's happening within, the clinics. I know there can be some hurdles, but still it should be in the interest of all of us and also in the interest of global human health. One of the things we're looking at ourselves is sewage, and that is basically to look at, okay, what's happening in healthy humans. That is also closer to what they get from the food chain. So of course, this is this angle that really has our keen interest. And why sewage? Well, basically because it's impossible or very difficult to get samples from individual humans. And there's also all these ethical aspects. I tried once to get samples from students at my university, but I was incapable of bribing them, even with beers Friday afternoon, and saying, okay, could you please come with me to the next room, bend over, take down your trousers, and I'll come with, the swab. And that didn't work. Sewage is great because it's automatically, mixturing from a large population, and there's no ethical concerns about looking into this. We ourselves use metagenomics. I know you can look at this in other ways, and that's all fair, but we prefer to go out and simply sequence all of it and then count the number of reads that are mapping to resistant genes. So that's what in our first pilot study, some years or actually published last year, we looked at sewage from 63 countries around the world. And at least in our analysis, it basically showed that, the world cluster in 2 different ways. This is, North America and Europe, and then the rest of the world. So I guess there is some kind of a separation there, at least in the diversity of antimicrobial resistant genes. We have continued this also to try to build a little bit more long-term and something perhaps even sustainable. In 2017 to 19, we are actually also sampling, we sampled this October and we'll sample again in April next year. So Some of you have probably contributed, so thank you for that. And we are up to 100 and actually 105 countries now, and also 27 countries where we have animals, from slaughterhouses, so sewage from slaughterhouses. So we can look at all the reservoirs and over time. We unfortunately have not looked at the animal samples yet, but if we look at all the data, we still see this very, very stable clustering of North America and Europe, and then the rest of the world across, whereas the bacteria roam is really, the clustering all over the place. So it's the same all around the world. Of interest is perhaps that if we look at the individual classes of antimicrobial genes, so the genes encoding resistance to individual classes, like in this case, tetracycline, well, then you can see that most of the countries cluster together, except Africa, that's kind of an outlier. In this case up here for the aminoglycosides is South America, and then Europe and North America. Again, here with macrolides, North America, Europe clusters together, and in this case down here with beta-lactams, really in Northern Africa and the Middle East. So showing that, at least for me, that if we want to understand the global emergent transmission of resistance, we really need to look at different things in different regions of the world. And we would love to compare this to other types of data. So it's not only our own sewage data, and especially reservoirs and human data. So we downloaded recently all available metagenomic data. So everything people have deposited in the short-read archive at NCBI, in this case from 780 projects, 150 terabytes of data. It took us 1 month to download, but we had to drop the firewall from our university. I think it took me 1 week to convince people we should do that. And then the analysis has been taken around 2 months on our HPC. There's still, if you look at this, most of the data are from humans, and very, very few from relevant reservoirs, animal reservoirs, and actually most livestock samples are from Denmark and from my, unfortunately, even from my own group. So I really love it if we could please get more data from livestock and reservoirs from around the world. Just one example of what you can start doing when we have these kind of data, in this case, MCR genes, not just MCR genes, but all the variants of the MCR gene around the world. So this is all the samples from everywhere. And then in this case, the MCR1, the first one, as you can see, very abundant in data from China, whereas up here, MCR9, very abundant in samples from the US, et cetera, and there's also other reservoirs over time. But really a pity that we have this transdimensional lack of data from reservoirs and over time. So I think that in conclusions, and I'm sorry I cannot give you the quantitative data, this is the importance and this is where we are, but basically, even after 25 years, we are still flying blind. And we do need comparable longitudinal global data to quantify the transmission of antimicrobial resistance. And I really think that it would be wonderful if an organization as the National Academy of Science could really say, okay, now we're going to take the lead on doing this and making it happen, or someone else, because it is not happening by itself, and it's not happening by individual research projects, short-term research projects around the world doing something. It really needs a long-term effort from someone that has a global voice. I do think that next generation sequencing and metagenomics are creating a common language so we can start collaborating and sharing more. But if reservoirs are not sampled and analyzed, it basically makes little sense. If we are still this completely narrow-minded focus we have that, oh, it's only humans that are important, we really need to look around and other places in the world. And then please, please, please send more standardized data. Thank you. And this is just some of the funds we get our money from, and without that, of course, there's nothing we can do. So thank you. That was all I had for today. And do any of you have any questions or comments?
Just in the interest of time, we are getting questions in, so I'm just going to jump in quickly here. Our first question is from our committee member, Guillaume Laramie, and it's in reference to that graph that you showed, the dissemination between animals and humans. And he's asking, do you have any idea of the gradient of what that dissemination would be, or the likelihood of some kind of outbreak arising from a veterinary medicine AMU?
But I think we have a very, very good data when it comes to the defined zoonotic bacteria like Salmonella, Campylobacter, that is, some of the classical well-knowns. When it comes to the reservoir in terms of the individual resistant genes and the mobilome, I think that we really lack the data there. There are some studies now starting to look at mobile elements and the context of the resistant genes, how they're moving around. That includes ourselves, and I think that might actually create some evidence. But if you do not have samples from both sides, from the animals and from the human sides, well, how can you quantify it? And I think that we really lack these data. For Salmonella and Campylobacter, we are fine, but it's for the rest that we're lacking the data. So I think the similar answer was no, I simply do not have the data to quantify that.
Okay, well, that's actually a good segue into the next question. This is from Marta Gomez-Chiari, and she says, how does the data need to be standardized in order to be best used, to be most useful? Oh no, where did my...
Yeah. So, well, I think that's, if we use something like a next generation sequencing to generate our data, then at least that part is automatically standardized. And I think that's really great, because then you do not have to be concerned about the methodology itself. That's at least a good step. Then there's some of the information around it. And this is, of course, if you deposit your data into a global repository, then at least if it's at ENA or if it's at NCBI or GeneBank, please remember to fill out the metadata so other people can use your data. When we downloaded these 150 terabytes of data, well, we had to exclude more than 50% of it because people have just used this as a trash place, dumped the data, and that's completely useless. So I think that if you could please just adhere to the international standards, then we would be one step at a time. Then I also think that it would be great if we could start standardizing a little bit more regarding other types of data, how you have collected your data and how you made it available. Scientific data, as the journal, is a good step, but perhaps if there could be a basic standard they could force people a little bit to use, then I think that we will also be a further step ahead. And I think that actually the National Academy of Science would not be a bad player in this area because, well, at least you have some, voice in the world. So, well, shouldn't you do something? Just a question mark.
Okay.
Well, you have more influence than I do.
I know that your time is limited, so I want to get to this next question. I don't know if you can read this as well, but it's from our committee member, Qijing Zhang, and he is asking, do you believe that NGS should replace traditional MIC tests for future global AMR monitoring?
Yes, immediately. So, and I can also argue for that, but yes, I think that's basically in our hands. That's in our hands. NGS, even a single isolates, is superior to traditional standards, susceptibility testing. And it's simply also just to remember, when you do phenotypes, you are also making mistakes. And I know that we all say, okay, but that's the golden standard. Yes, it is. But if you compare data from two laboratories, there's still a lot of mistakes. NGS do not make the same mistakes. You might be missing something, that's true, but overall, I do think that this actually creates better data. I wouldn't exclude, the phenotypes. I love phenotypes. I would almost dare to argue that I've probably done more phenotypic tests than most of you. Well, I have, definitely. I love it, and I'll continue to do that. But I do think that there's so many advantages of NGS that, yes, I think we should replace the traditional with the NGS, at least in the very near future.
All right. Thank you very much for that presentation and for joining us from Denmark today. Thank you, Dr. Erstrup. And thanks to everyone. I think we are going to stay on time pretty nicely. We have time for more questions later if you're able to join. And right now we're able to go to our next speaker, From the College of Veterinary Medicine at North Carolina State University is Mark Papich. Looks like you're all set up
I'm
there.
here. Thank you very much. Thank you for inviting me. I appreciate the opportunity to talk with such a great group and such a prestigious organization. And I've enjoyed. I wasn't able to listen to all the presentations yesterday, but of the ones I listened to, I was really impressed and enjoyed it quite a lot. So I'm going to switch to my screen share, okay? And if it will pop up here, here we go. Oops, we'll go to the beginning here. So as you can see from the title, what I've been asked to speak on today is the antibiotic use in companion animals. And when I say companion animals, I'm really limiting this to dogs and cats. Some of these comments might be applicable to horses as well, and even exotic animals as well. But I'm really confining it for most of my discussion to dogs and cats. So this is a little bit of a shift a bit because as you just heard, for example, in the last presentation by Frank, so much of the focus has been on food animals and food animals acting as a reservoir for resistant bacteria and measuring antibiotic use in those food animals and so forth. So this is a little bit of a shift, and we have to ask ourselves where companion animals might fit into this scenario and if they do at all. I do have some disclosures. There's really nothing that pertains much to this presentation. Some of the products I might mention, I may have done work with these companies, but that's the extent of my disclosures here. So let me start out by just reminding you of stuff I'm sure this audience already knows. In just last year, the CDC published their report on antibiotic resistance threats in the United States, and this is a updated version of one that they produced previously. And I think most, as I said, most of this audience is aware of this report and has probably examined it. And you'll notice that on their report and in the report, they list various bacteria that can be drug resistant and could be urgent threats or serious threats. And a lot of bacteria are listed. Well, we have a similar issue in veterinary medicine with antibiotic resistant threats. It's not the same as what the CDC reports for humans, but we did explore this. In fact, we did this quite recently. I serve on the AVMA, that's the American Veterinary Medical Association Committee on Antimicrobials. And our committee recently, well, it was over the course of about a year, put together a list for each species, each animal species, of the antibiotic resistant threats. And these are threats to the animal and make treatment difficult in the animal. However, we can't ignore the fact that these bacteria could potentially be transferred to people as well. So this is, in fact, on the AVMA website, one can access this report, and there are areas identified for companion animals that I'll talk about in a moment here, food animals, equine, aquaculture, and so forth. So this is the list we compiled. For companion animals, and again, meaning dogs and cats, we did put together a list of pathogens of concern. And this is either identified through some surveillance mechanisms, review papers, consensus from experts, and so forth. And it's hard to read on the slide on the right-hand side of the slide, so I've enlarged it here. And you'll notice some familiar bacteria. And these are all problems in veterinary medicine in our companion animals and that we see in dogs and cats. Methicillin-resistant Staphylococcus, for example, has become quite a problem in dogs. We don't see much Staph aureus, but we do see another species of Staphylococcus, and it is very similar to Staph aureus in the way it responds and the resistance genes and so forth. We see it also in cats. We see the ESBL producing Enterobacteriaceae, E. coli most often, but we see this in Klebsiella as well, also Proteus and some of the other gram-negative bacteria. We see drug-resistant Pseudomonas, that for chronic infections, that becomes a problem. We also see drug-resistant Enterococcus. So we see a lot of these, bacteria that are you've all heard names of before, And these are indeed a problem that we encounter in dogs and cats. Some of these have become worse. Methicillin-resistant staphylococcus, for example, has been one of growing concern that has emerged primarily in the last 10 years. And the same is true for the ESBL-producing Enterobacteriaceae. That's been a problem emerging and I think perhaps getting a bit worse in the last 10 years or so. So there's two problems here. One is that our pets acquire these infections and need to be treated, and we have to come up with things to treat them with or find agents to treat them with. The other problem is when they harbor these bacteria, what the potential threat might be to the humans that live with these pets. As we all know, dogs and cats are part of our family. We live with them very closely. And if they're harboring some of these drug-resistant bacteria, is that a problem? And the focus always has been more on food animals. This is also from the CDC, one of the CDC's reports, and it reminds us of how resistance spreads, right? And we've seen these charts or something similar to it previously. On the right-hand side is the human situation where humans receive an antibiotic and how that gets transmitted through the community. On the left-hand side, it's food animals listed. You see poultry, cattle, and pigs listed. And it reminds us that when these animals get antibiotics, they acquire drug-resistant bacteria. These can be transmitted through food. People acquire these, or these bacteria can be transmitted into the environment through feces, for example, and get into the environment, and that's a source of infection in people as well. So the focus has always been, it seems to be mostly on food animals, but we can't ignore the potential risks that pets have to us as well. And this, some of these old pictures and some of these very beautiful artwork remind us of the close relationship that our pets have to us in our homes. They sleep with us, they eat with us, they play with our children, they lick our children, and so forth. And this illustrates that quite well. So we have to ask ourselves, are there some risks when these pets may harbor resistant bacteria? And how can we mitigate that? So that is a growing concern. I don't have any solutions. We need more solutions, certainly, but I just want to remind everybody that there are some potential risks. So how are we going to manage these? One of the things that we do not have is approved antibiotics that can treat some of these infections. We have antibiotics that we borrow from human medicine. We use human drugs in an extra label manner, but we have very few that are approved in companion animals to treat these. So we need more effective antibiotics. The problem is there's not enough new drugs in the pipeline. It's been a really discouraging to see how few antibiotics have been approved in recent years. No new drug approvals, for example, since 2012. That's a long time not to have any new approvals for these companion animals. So there's a dire need for some of these agents. We also recognize that the use of these in companion animals do indeed, just like any animal or a person for that matter, when we use these drugs, we do recognize that there is the potential for selecting for resistance, and those resistant pathogens can be a risk for human health. We can't ignore that. Regarding the antibiotics that are available, this is actually a review article that just got published that I was asked to write for a special issue of one of our veterinary journals. And when I started researching and gathering data to write this paper, I was a bit surprised and disappointed at how few antibiotics we have in the pipeline or available currently. And I mentioned that on the previous slide. I knew it was bad, but I didn't realize that it was this dire. For example, since 1997, only 6 new antibiotics were approved for dogs and cats. 3 of these were fluoroquinolones, which they're all in the same class and they basically do the same thing. There was 1 new first-generation cephalosporin, which was cephalexin, and 2 third-generation cephalosporins. So those of the 6, that is it. That's all that have been available. The problem that we have currently is that we have all these old ones. old ones that approved before 1997, and in fact, many of those that are currently available and have label approvals go back probably 30 years or more. And these are old. And when that paper I just mentioned, I reviewed the labels for many of these older drugs. They are outdated, the doses are outdated, the indications are outdated. And these are, as I indicated in my slide, these are potential targets for reduction. One of the earlier speakers today cited, maybe ways that we can reduce the overuse and misuse of some of the antibiotics to reduce the overall use. And one way to start would be to either revise the labels, or in fact, if I could, I would get rid of some of these. I don't have that power, but they should be reviewed, certainly. So because of this deficiency and these unmet needs, we do indeed in the United States use a lot of human labeled drugs. I realize that in Europe there are more restrictions, but in the United States it's wide open. In companion animals, since we do not eat them and they don't enter the food chain, we're allowed to use any antibiotics that we can acquire legally, including human antibiotics. So what are some of these? We use an awful lot of, for example, doxycycline and minocycline. It's very common in dogs and cats. Even though these are not approved for those species, we use the human generic version. We use rifampin for the methicillin-resistant staphylococcus, and occasionally for other bacteria. We do use quite a bit of rifampin, believe it or not. We use injectable third-generation cephalosporins, drugs like ceftazidime, that is approved only for humans, but we use it also in veterinary medicine, and we use it as well in our exotic animals. Because of the availability of the veterinary fluoroquinolones is sometimes a little bit more expensive, or maybe not in a convenient dose form, we actually use a lot of generics. We use generic ciprofloxacin, we use generic levofloxacin. And in veterinary medicine and our companion animals, it's completely legal. These are cheap, some of these incredibly cheap, and it's quite surprising how widespread the use is. Believe it or not, we use carbapenems as well. We get some of these, let's say, ESBL producing bacteria, and when we get an ESBL producing organism, sometimes we have very few choices. So it's either we ignore the infection, which is not tenable most of the time, or perhaps put the animal down, or we treat them. And sometimes it's a carbapenem, most often meropenem. We find meropenem is, of them all, is the easiest for us to administer. We use aminoglycosides like amikacin as well. Believe it or not, we use linezolid. We encounter some infections that are resistant to other agents, and sometimes, rather, the only other one might be available would be vancomycin. We don't use very much vancomycin, but linezolid, being an oral drug, it surprises people, and I know that it upsets certain people. But believe it or not, linezolid is used, and we can't restrict that. There are no restrictions if a veterinarian wants to write a prescription to a retail pharmacy for a drug like linezolid. Well, the problem is we recognize that some of these drugs, many of these, in fact, all the ones in the earlier slide, have been classified by the WHO as critically important. Some of these are in the, I know this audience is very familiar with this list. Some of these drugs are in the highest priority list, some are on the high priority list. Of the highest priorities, these are many of the drugs that I just mentioned. We have approved third-generation cephalosporins, and we use some of the human label cephalosporins extra label. We don't use much vancomycin, but it is used occasionally. We use a lot of macrolides, even azithromycin, for example. We don't use much in the way of polymyxins, but we use an awful lot of fluoroquinolones. So these are all on the highest priority list, yet we're using them in our companion animals. If we go to the high priority list, yeah, we use all of these drugs. We use the aminoglycosides, as I just mentioned. We do use some of the carbapenems. We use linezolid, and we use an awful lot of the penicillins. In fact, amoxicillin and amoxicillin clavulanic acid is probably the most frequently prescribed oral antibiotic for dogs and cats. That we know from certain surveys. And as I mentioned before, we do use rifampin occasionally as well. So that creates a dilemma. That creates a dilemma for veterinarians. We recognize that these are important drugs, yet we have pets that need to be treated. And that is a hard problem to reconcile. So how can we possibly minimize some of the risks that we might be creating? Well, we do have stewardship programs. So some of the antibiotics that I mentioned, such as linezolid, third generation cephalosporins, and even fluoroquinolones, I don't want to imply that we use them without any guidance or just willy-nilly, indiscriminately. We do have stewardship programs. These aren't required, but in hospitals, whether it's a university hospital, a specialty hospital, or even local hospitals, we encourage stewardship programs. We can't enforce them, but we do encourage them, and the AVMA has been very active. So in a way of stewardship programs, as much as possible, try to control the infections in our hospitals. That is screening, restricting. We have restriction policies in our hospital here at NC State. One of the things that I've been involved in is just education, encouraging and educating veterinarians that at least if we are to use these drugs, or even for some of our older drugs, for goodness sakes, let's use the right dose, the right frequency, and if possible, the shortest duration that we can. In other words, we should at least use the drugs appropriately. If we don't, we're just encouraging resistance. We try to, as much as possible, promote good compliance so that animal owners will follow our instructions and use the drugs appropriately. And that's another guideline that we have. If we do see a resistance strain, we try to treat it appropriately. As I said before, when a pet has a resistant bacteria, whether it's methicillin-resistant staphylococcus or an ESBL-producing bacteria, we don't have many options. We can't ignore it because they are shedding resistant bacteria. We can't just let it fester because now the pet is suffering. I guess the third option might be euthanasia, but remember, these pets are members of the family in many homes. And that third option is simply not reasonable in most of the situations. We have revised some guidelines to encourage a short of course as possible. We all know that the importance of that in reducing resistance. And then we encourage as much as possible following guidelines, following appropriate guidelines, since many of these older drugs have outdated labels and things like that. And we also use human drugs for which we have no label. We have to have some guidance to help veterinarians use these drugs appropriately. So we do have some. I've been involved. I've been very proud of the fact that my involvement with this group is called the International Society for Companion Animal Infectious Diseases. And you can go to their website and learn more about them. It's a nonprofit organization. And through them, I've been involved in the production. Now we at this point, we have 3 guidelines, and we are currently working on at least 3 more. This one was published for guidance on treating respiratory tract infections in dogs and cats, a very common problem that we see. These guidelines were for the treatment of urinary tract infections. And a lot of work went into it. This took, in fact, this is an updated version. This took almost 2 years for us to get through. And we revised a lot of the recommendations for treating simple urinary tract infections in dogs and cats, which many veterinarians, in our opinion, were being treated inappropriately. And we're currently updating our guideline for treating skin infections. Skin infections are probably the most common infection that veterinarians encounter. This one was published in 2014, so we see a need to revise it, and we are currently working on that. So we're trying, right? We're trying to put out consensus-driven guidelines to help veterinarians. We do have these, so there are some encouraging developments. There are more guidelines available. Some are in the works that we are producing. This is the ISCAD group that I mentioned. These, as much as possible, we try to make them evidence-based. We discourage the indiscriminate use of antibiotics that are not likely to work. We discourage long-term antibiotics that is unnecessary, and so forth and so on. Another thing that, in fact, I've been involved in this a lot through my own research, is to educate veterinarians how to use these drugs better and smarter. And the way that we do that is employing PKPD principles. We have gone through a lot of old drugs, for example, and I've been involved in that through my work with CLSI, and revised dosing regimens and use recommendations using PKPD principles. In other words, using good science. to guide veterinarians on the proper use of these drugs. And as I just alluded to, we do have more susceptibility testing standards available now than we ever have had before. So I do not want to imply that some of those drugs that I mentioned previously, whether it's a human drug or whether it's a fluoroquinolone or something like that, that we should be using more discriminately. We don't use those without any guidance. And I've been involved quite a lot in developing susceptibility testing standards for these drugs. This is, of course, through CLSI. There's no European version of CLSI. UCAST, for example, that many of you are aware of, UCAST does not have animal breakpoints. So there has to be one source. And that comes through one of the subcommittees of CLSI. And this is the veterinary antimicrobial susceptibility testing subcommittee. I've been involved with this group almost since its inception in 1993. I was the chair for 6 years. I'm currently involved a lot. And one of the things that we try to do is look at these drugs, even though they may not be labeled for animal use, or maybe we use them in an extra label manner, we still need to test for them. And we have to have accurate and reliable tests. And so we establish interpretive categories and breakpoints for these drugs, as many of them as we can. It's a continual process. We publish them, we make them available, we update old drugs or old labels or old recommendations. And then finally, my last bullet point there is to educate people about this. In the time that we've been involved with this, I have to say that veterinarians are more aware of the importance of susceptibility testing to help select their antibiotics than ever before. Several years ago, that wasn't the case, but I think we've done a better job at that. We've published our documents, made them available. These are available, and there are free versions of this available online, by the way, that veterinarians can access. This is our most recent report. I'm very proud of this one because this took about 2 years in the making. It just got published last year. And as it implies in the title, this was specifically aimed at providing information to veterinarians and laboratories that do testing on how to understand these tests and how to interpret them. And this is all aimed at improving antimicrobial stewardship in veterinary settings. And this document, as I said, is our most recent publication, and I think it has helped quite a lot. So I'm going to wrap this up so we can get to some questions. I just want to remind people, the audience, of one of the disappointing things is that we don't have any new drugs in the pipeline. I wish we did, but if there are any new drugs that come about in veterinary medicine, it is likely to be from an existing class or perhaps a copy of an old one. We're not going to get any new antibiotics for these pets. It's just not going to happen, and we can't hope for that. I wish we could, but it's not going to happen. So here we are. We're faced with using existing antibiotics better and using other drugs, off-label drugs, to meet our needs. And this will, I'm afraid, continue to require that we use human label antibiotics. At this point, there is no effort to restrict the use of human label antibiotics in companion animals. In food animals, that's a different situation. There are many more restrictions in food animals. At this point, in small animals, at this point, we can use any drugs that veterinarians can get our hands on. So we have to use the ones we have smarter. If we're not going to get any new ones, we have to use them smarter. And so that's what I have been talking about, is educating veterinarians, educating the people in our veterinary schools so that they can teach our veterinary students more about this, getting accurate breakpoints for testing and stewardship guidelines and guidelines for treating. So if we're not going to get any new ones, we have to do a better job of using the drugs that we have available. As I alluded to, at this point, there are no restrictions. But since there are no restrictions on some of these drugs like linezolid and carbapenems and third-generation cephalosporins, we do have to be responsible. We have to be responsible in the way that we use these drugs, and that's another part of our education. I would hate to see, drugs like our third-generation cephalosporins or linezolid or our carbapenems be used indiscriminately. That's a part of education that we have to pay close attention to. And we do have, as I said before, we do have our stewardship guidelines that help with this, and they rank antibiotics and provide tiers that veterinarians can refer to. In other words, first tier, second tier, third tier, and so forth. It will help guide veterinarians on what drugs are appropriate to use first and which ones you should reserve only if needed. And as I mentioned as well, I'm very happy to report that we do have testing standards available to guide the use of many of these new ones or existing drugs. And I think that has helped our situation quite a lot. And we're going to continue that effort. Our CLSI committee meets once a year, sometimes twice a year, and we're always pushing forward to update the existing standards that we have. So with that, I'm going to stop, and I hope there is time for questions, but I want to indeed thank you for your attention. And if I provided some contact information, if anybody does need to get in touch with me for any reason. So I'm going to turn it back to our chair and see if there's anything else. Let me stop my screen share.
All right, thank you. Thank you, Mark.
See if we have any time for questions. I'm not sure if we do.
I think we do. We've got just a few minutes, and there's a couple questions. First of all, thank you very much, Mark, for your presentation.
Oh, sure. It was my pleasure.
And unique for us. The first question is, are there, perhaps on a national or regional basis, data and monitoring? What kind of data monitoring is occurring for use of antibiotics in companion animals?
Yeah, I'm glad you asked that. And, I was, after listening to some of the earlier presentations today, I thought to myself, geez, I should have included that in my slides. The answer is no. And now what we can get are, maybe if we do surveys of veterinarians or send out a questionnaire to veterinarians, we can get information on what they prescribe the most often. But that's very limited, and it's based on the survey data. We don't have any national program to get that information. Individual companies, individual sponsors may have their own internal data, but that's as far as it goes. The problem is we use a lot of human drugs, extra label. Those come from distributors. Veterinarians can write prescriptions to a retail pharmacy. So there's no way of tracking that data. The best that we have is perhaps maybe an individual sponsor that sells antibiotics. They may have their own internal data, but that doesn't even capture some of the drugs that they may have that are generic drugs and sold through another company. So disappointingly, the answer is no. And I might add, in terms of resistant pathogens, we also have no national monitoring system for companion animals. They do for food animals, like there's NARMs and so forth, but not for companion animals. The only thing we have are maybe individual hospitals or regional labs that may collect data, but no national monitoring system.
Two other quick questions. One is really interesting, is any studies on the impact of pet waste, obviously fecal contamination, especially with the increase in things like dog parks, where, if every cat goes its own way, it's not as big a problem as if you get this clustering. Any impact of that, or studies on that you've looked at?
Yeah, believe it. There actually have been studies on that. There have been studies done where they sample feces, for example, in dog parks. And what they find is that indeed they can find things like ESBL producing bacteria in dog parks. There's also, now the thing that we don't know is the risk that these findings are to humans. We don't know what the spread might be, but it's very interesting to learn that, that you mentioned the dog parks where they have identified this sort of thing. Also within a household, we know that the bacteria in pets is shared with humans. They often have the same, interestingly, bacteria. If they go into a household and sample the pet, the children, and the adults, they find that they harbor the same bacteria. So there is sharing, and it goes both ways, by the way, humans to pets, pets to humans, sibling to sibling, and things like that. What we don't know is the impact of that. So if, for example, if a pet were to harbor a resistant bacteria, does that become a threat to people? The only studies available so far are some, these are small, where they identified resistant bacteria in pets and then looked at the humans in the household to identify whether or not they acquired a resistant urinary tract infection. And so far, there's no evidence of that, but that's very limited at this point. Any other questions?
All right, I've got actually about 3 more questions, but we're going to have to hold those. Hopefully we'll get back to those. If not, we will get those to you because I think they're quite relevant.
Yeah, that sounds great. Yeah, I'll look at the chat questions, and if there's perhaps even if I can just type in an answer on the chat, I'll try and do that as well. Okay.
Okay, we'll get those to you. Thanks again, Mark.
I appreciate it. Thanks for inviting me. I really enjoyed this.
Oh, it's been a pleasure.
Okay.
All right, Jillian, back to you.
Oh, that's fine, Guy. We just need to introduce Dr. Cabello from the Department of Microbiology at New York Medical College. Felipe Cabello. There we go. Can just go ahead and share.
Here. Okay, I'm going to thank the committee for inviting me to present our experience on the use of antimicrobials in salmon aquaculture in Chile. First, I would like to say that this work has been the result of many collaborations in Chile, in the United States, and also in Norway. And it was possible because it was funded by the Land Face Ocean program of the Pew Charitable Trust, and also because I obtained a John Simon Guggenheim Foundation Fellowship. Salmon aquaculture in Chile began like 25 years ago. And as you know, the wild cycle, the wildlife story of salmon can be reproduced in an artificial manner in aquaculture. And that has been quite a technological achievement. And as you know, probably salmon is an anadromous fish, and it needs growing in fresh water and also in the ocean. And this has been reproduced in salmon aquaculture in Norway, in Chile, also in the United States, and in British Columbia and in Ireland, among other countries. In Chile, the fresh water cycle of the salmon usually is achieved in these alpine lakes that are in the southern part of the country. From there, the juvenile forms of the fish are grown, and they are transported to the sea in these trucks that you can see here. This truck is in a ferry. This is a tank that is being oxygenated, and the fish, the juvenile fish, the smolts are transported to the sea to be fattened in this area, in this archipelago south of Chile. And you can see here then the fattening cages of salmon in the sea. Now, when we began this study, it was very difficult to obtain information about whether antimicrobials were used in salmon aquaculture in Chile. At the beginning, the industry and the government said that no antimicrobials were used. But as evidence grew, they could not continue denying that antimicrobials were used. And as you know, this is a problem in all aquacultures. Aquaculture is growing in the world, and is surpassing the capture in the sea of wild fish, and the increased use of antimicrobials in aquaculture then is an increasing problem because aquaculture is growing. And this happened in Chile too. And you can see that from producing a few tons of fish at the beginning of the 80s, Chile almost produced now 1 million tons. And as you heard before, that Norway produced over 1 million tons, metric tons of salmon. And with this increase, the antimicrobial use has increased. And as I told you before, at the beginning it was quite difficult to obtain information about how much antimicrobial were used in salmon aquaculture in Chile. But then a collaborator of mine in one of the universities in the south of Chile got the idea of looking at the information of how many foreign currency the banks in Chile, the central bank in Chile, was providing to salmon aquaculture company to buy antimicrobials, because antimicrobials are not produced in Chile. And with that information, going to the Central Bank of Chile, we could establish that as salmon aquaculture production in Chile increased, the consumption of tetracycline and florfenicol and quinolone also increased. And this indicated that then salmon aquaculture was one of the major consumers of antimicrobials in Chile. Now, we also were able to ascertain, and with information from Pesca in Chile, that is the regulatory institution for the salmon industry, that most of the antimicrobials are used in the fattening stage in the sea, in the marine environment, in the cages for fattening, and very little antimicrobial, 3.5%, is used in the fresh water phase of the production. We could also see with this information that two things here, that while the consumption of antimicrobials for human medicine stay more or less constant, the consumption of antimicrobials, and in this case fluoroquinolones for salmon aquaculture, for veterinary medicine, increase. Another important thing that we realize here is that, you know, with this importation data and this authorization data, that the regulatory institution in Chile, the veterinary regulatory institutions, also only have control on a small amount of antibiotics use, okay? And there was a large amount of antibiotics that were used without having any control by the regulatory institutions in Chile. And this thing got a little bit better later when we began our investigation. And you know, but there was still an important amount of antimicrobials that were not under control. They were not registered that they were used. And here in fluoroquinolones, something that I already told you, you know, most of the use of fluoroquinolones, of flumecine and oxalic acid, was done in aquaculture, and a very small amount of it was done for human medicine. And the situation, and this slide, I have to apologize for this, the titles are here in Spanish, but I got it just 2 days ago. The situation has improved somewhat, but still the aquaculture in Chile uses, you know, 300, 390, 500 tons of antimicrobials a year, which is almost 50 times, 80 times more than what is used in human medicine. And if you compare Chile with Norway, you know, the amounts of antimicrobials that different companies in Chile use are, you know, 200 times, 300 times, 700 times more than the amount of antimicrobials are used in Norway. Then the following question was does this use of antimicrobials in the aquaculture and the marine environment has any effect? Well, you know, the antimicrobials are given to the fish in the food, in the feed. Okay, and then the fish ingest the food, and you know, and the antimicrobial is absorbed, but a large proportion also is excreted to the sediment here, to the sediment, and also the urine of the fish is rich in antimicrobials. And also some of the feed is not ingested by the food and by the fish, sorry, and goes directly to the sediment in such a way that here in the sediment and some also in the water, you have large concentration of antimicrobials, large concentration of feed. You have the normal flora of the sediment, and also you have the normal flora of the stool of the fish. And you create in this area something that a colleague from Norway called, Henning Sørum, called a hot spot for generation and for selection and recombination of antimicrobial resistant genes. And then we decide to investigate whether this antimicrobial use in salmon aquaculture in Chile had any effect. And we went to these areas and we decided to investigate the sediment there. And this is our study point. This is a control point, 5 meters from the study point, 1 kilometer and 8 kilometers from the study point. And we decided to look for antimicrobial resistance in the sediment. Here you have the cage. There was a diver there that went down to the sediment, extracted samples, and here is the control where the same procedure was done. And you can see in this slide that through the year, the sediment below the cages, the salmon cages in black, had significant more resistant bacteria to tetracycline, to oxalinic acid, that is a quinolone, and only twice in the year we tested, the same was true for fluorphenicol. Then it was clear that these antimicrobials that were used in salmon aquaculture were altering the sediment and selecting for antimicrobial resistant bacteria. And we tested also whether there was a gradient in the resistance from the point of where aquaculture was taking place to the control, and you can see that that is the case. There is a gradient, okay? And we look for antimicrobial resistant genes in these bacteria, and we found resistant genes to quinolone by doing PCR, resistant to tetracycline, resistant to fluorphenicol, that are the antimicrobials that are used in salmon aquaculture in Chile. And this is the same. We found antimicrobial resistant genes in the aquaculture site and in the control. And an important thing that I didn't mention is that we also find residual antimicrobials, not only in the aquaculture side, but we also find it in the control side. And that is explained because the amount of antimicrobials are so large that are carried out by the currents to far away distances from where aquaculture takes place, and they exert their selective pressure there too. And another important thing we did is we look at this, the 16 sRNA of these bacteria, and all of them were marine bacteria, because you have the possibility in these areas, sometimes the sewage is not treated properly, that the resistance might belong to bacterial, human bacteria, but that was not the case. All these bacteria were bacteria that were marine bacteria from the sediment. They were autochthonous from the sediment. And other study was done by other colleagues, and they look at the resistance in the intestine of fishes, and they found large amounts of bacteria resistant to many antimicrobials in the fishes that were treated with antimicrobials. Then it is clear that, as the people in Norway describe, these sites of aquaculture are hot spots for selection of antimicrobial resistance, and probably also for stimulation of genetic transfer of antimicrobial resistant genes and antimicrobial resistant elements between different bacteria. And the next question we ask is there is horizontal gene transfer between marine bacteria and animal and human pathogens. And bacteria can transfer antimicrobial resistant genes by conjugation, by transduction, and by natural transformation. We did conjugation experiments, and we could show here we have one bacteria from the aquaculture site, another bacteria from the aquaculture site, that can transfer their genes, their antimicrobial resistant genes, to a susceptible recipient, indicated that these bacteria in the marine sediment that are being selected by aquaculture use of antimicrobials can transfer their antimicrobial resistant genes. And also we found that these bacteria contain large amount of plasmids and also integrons that are involved in the ability of the genome of bacteria to capture antimicrobial resistant genes from the environment. And we also show that many of these genes, in this case, the tetracycline resistant genes B, K, and M, and this is the quinolone resistant gene, are also found in the urinary tract of bacteria isolated from urinary tract infections in hospitals in these areas of aquaculture. That indicating that probably there is transfer of these antimicrobial resistant genes and these plasmids and integrons between bacteria from the marine environment and bacteria that consider human pathogens as Escherichia coli. This is something also we look at the sequence of amino acids of a protein that give resistance to quinolones in an E. coli isolated from a urinary tract infection in this area. And 4 bacteria, Rhodococcus, Erythrobacter, Chaetococcus, Sporosarcina, isolated from the marine environment. And you can see that the sequence of amino acids of this protein that this protein that mediates antimicrobial resistance to quinolones is totally similar, indicating that probably there is transfer of antimicrobial resistant genes between the bacteria of the marine sediment and the ones isolated from urinary tract infections in patients from this area. And we look at the genetic structure of the integrons, and we also observe that the integrons in marine bacteria and E. coli isolated from urinary tract infections are also very similar. Then our hypothesis is that this antimicrobial use in the aquaculture is selecting for antimicrobial resistant bacteria in the sediment, and probably there is transfer of these antimicrobial resistant genes to the normal flora and pathogens of people living in these areas. Now, this is our hypothesis that what you do here, in the marine environment with the use of antimicrobials has repercussions in the hospitals in the area, because urinary tract infections, E. coli, contain the same genes that are isolated in the bacteria here. And this is under the One Health concept. We are using antimicrobials to treat the fish, and we are creating antimicrobial resistance in the environment, and this antimicrobial resistance in the environment has the potential to impact human health because the genes and the genetic element responsible for antimicrobial resistance here are able to transfer to bacteria of humans. And another important observation we did is that this increased antibacterial use in salmon aquaculture in Chile is related not to increased fish health, but is related to decreased fish health, because you can see here that it's taking more time to get a adult salmon from a small as the antimicrobial use increases. It takes, from one small, you get 3.7 kilograms of salmon in 2003, and this goes down to 3.14 in 2007. And also another index that this antimicrobial use is having a detrimental effect in salmon aquaculture is that it's taking more days in the sea to get a salmon that is mature and can be marketed. Okay, I'm not saying here that this antimicrobial use has this effect, but in such a way it appears that it's not related to an increase in the quality of fish health. And it even might be detrimental, and that is something that probably should be studied. And you can see here too that as salmon production has increased in Chile and antimicrobial use has increased, there has been emergence of new pathogens, rickettsias, Yersinia, Vibrios, and so on. Then, here you have a situation where antimicrobial use, excessive antimicrobial use, is affecting negatively the health of the environment, of the fish, and potentially also human health. And under the One Health paradigm, it will be very important then to do surveillance of fish and pathogens, bacterial pathogens of fish, to prevent the emergence of antimicrobial resistance in the environment, in fish pathogens, and also in human pathogens. In conclusion, I think it is clear that, as was hypothesized 25 years ago in Norway, it appeared that these sites of aquaculture, by this excessive use of antimicrobials, are becoming hot spots for selection of antimicrobial resistant genes, selection of antimicrobial resistant bacteria, and also with a potential negative impact in human health. And I think I would like to finish here. If there is any questions, I'm open. Thank you very much.
Thank you very much, Felipe. We have a couple questions specific to your presentation, and then we may be able to go back to some others if we still have those presenters available. I think some have, depending on their time zone, moved on to other either obligations, professional or personal. The first question, Felipe, is what are the differences between Norway and Chile that has allowed Norway to raise salmon with essentially no use of antibiotics? Is it strictly vaccines, or is it more complex than that?
Well, that's something that interested me a lot, and the major pathogen in salmon aquaculture in Chile is an intracellular pathogen called Piscirrhizia salmonis. Okay, and Piscirrhizia salmonis exist everywhere, even in Norway. Okay, but in Norway, in British Columbia, in Ireland, in the United States, here in Puget Sound, in Oregon, it's not a pathogen at all. Okay, and when you look at the literature, it is clear that this pathogen is a relative pathogen. And it appears that in Chile it's more pathogenic or has an increased pathogenicity because the conditions of raising salmon are different. You saw, I showed you the track that is used to transport the fish from the lakes to the marine environment. Well, the fish there are stressed. They are under a lot of stress because there are vibrations, the concentration of oxygen is not the best, and that favored infection with bacterial pathogens. And those tracks do not exist in Norway because the hatcheries are very close to where the salmon is fattened in the marine environment. Okay, and in Chile they have tried to develop vaccines against Piscirrhizia salmonis, and there are like 35 or 37 in the market, but no one of them has proven effective. And that is one of the reasons that so many antimicrobials are used in Chile compared to Norway.
Okay. Yeah, thanks very much. The other question is, how do you, what's your opinion on how the transfer of resistance occurs or may occur between the salmonid industry and humans?
Well, you know,
through a shared environment, through the fish, through et cetera.
My hypothesis is the following. You know, many of these areas where salmon is grown, they have no adequate sewage treatment plants. And then in the environment in Chile, it is in the marine environment and also in freshwater environments, it's not unusual to find commensal bacteria of human origin, such as Escherichia coli, Klebsiella. And I believe that those bacteria probably are the bridge between bacteria of the marine environment, bacteria of the intestinal tract of salmons, and salmon pathogens, and human pathogens.
Okay. Yeah, thank you. Could I ask you, Felipe, to stop your screen share? That might be helpful so I can.
Okay.
There you are. One, I can see your handsome face. That's good. But also I can see other questions and who all might be with us. One of the, yeah, that's great. One of the questions that Andy Stragachis had for Mark Papich, if Mark, yeah, I see Mark's still available, is what role that community pharmacists may play in the companion animal prescription guidelines.
Yeah, you know, that's a good question. I think they could play a role. However, currently, the vast majority of antibiotics for dogs and cats, as well for horses too, probably, are dispensed from the veterinary practice. The only ones that they might write a prescription for are maybe some of the more lesser used antibiotics and ones that might be too expensive to keep in inventory in the hospital. So the vast majority of antibiotics are dispensed out of the veterinary practice. In other words, the veterinarian is the pharmacist too. And they have an inventory in their hospital. They buy all their drugs through distributors. And as I mentioned before, all of these are widely available. So anybody can buy them that wants to. So the answer, I think, is potentially, but not under the current system, unfortunately. Now, having said that, you know, as I just described, that does raise questions about, you know, potential conflict that a veterinarian has, that they are the ones selling the antibiotics and making some money off of it, and they're doing the prescribing. And there has been some concern about whether or not that constitutes a conflict that for veterinarians to perhaps prescribe more antibiotics than they ought to be. We don't have a lot of data on that, so I don't know the real answer, but I know that question has been raised in some countries. I know Sweden, for example, is one that comes to mind. They passed a law that says that every antibiotic for a companion animal has to have a prescription that is filled through a retail pharmacist. So no longer do veterinarians have the prescribing ability. And I know that based on some data, that reduced the overall antibiotic use in companion animals quite significantly. That's the only country I'm aware of that has such data. Sorry for such a long answer, but I thought it reminded me of some other points I should have made earlier.
There's another question about, again, for you, Mark, is how frequent is therapeutic failure due to multi-drug resistant bacteria in companion animals? Do you have a sense of?
Oh boy, I don't have a good answer to that. I just don't know. If I can say this, that if they are using some of these older, outdated drugs that don't have accurate dosing or stuff like that on the label, therapeutic failure, I think, is rather common. That's kind of my impression. And then that's why, I tried to emphasize in my presentation that we're trying to educate them. Maybe we start with our students and teach them to use these antibiotics in a wiser way. But the real answer to your question is, I wish I knew, but I don't have data on that.
All right. Do we have any other questions? There were a few other questions, but I think they're for our individuals who are in the northern part of Europe and have probably moved on to other activities of the day. Any other questions that the panelists would like to ask? You can either put them in chat or do your virtual raise your hand, or actually raise your hand. Any of those work. Felipe has a question, or
no? I would like to make a comment that
Sure.
Another way that antimicrobial resistant genes and antimicrobial resistant elements might come to the commensal flora of humans and pathogens of human pathogens is through the fact that sometimes the meat of the fish might be contaminated with bacteria of the intestinal tract of the fish, or even from bacteria from the marine environment that contain antimicrobial resistant genes. And the ingestion of these bacteria by humans could produce theoretically in the intestine of humans the transfer of these antimicrobial resistant genes and antimicrobial resistant genetic elements to human commensals and human pathogens. And that is something that has not been studied very much.
Thank you, Felipe. Kijing has a question, and then Mary.
Yeah, I have a question for Mark. This is related to extra label use of antibiotics for pets. So you elaborate, you made a comment, it's quite common, and there's no restriction. I just wonder, does that mean there's no, a regulation or any, kind of a policy in terms of extra label use in companion animals?
You're exactly right. There are no restrictions. And what happened? Oh, geez, it's been many years ago now. Is that our U.S. Congress passed a law, and they call it the AMDUCA, Animal Medical Use Drug Clarification Act. And what it says is that for food animals there can be restrictions because food animals, of course, enter the food chain. So that's different. If it is a non-food animal, companion animals, it's wide open. There are no restrictions. Any extra label use is allowed, whether it be extra label drugs, extra label dosages, anything. It is wide open. So absolutely none. And I have to say, there are no efforts that I am aware of to place any restrictions. Not in the United States. I realize that it is a different situation in some of the European countries, but in the United States, I don't see that changing anytime soon.
Thank you.
Thank you.
Mary.
In food animals, there are restrictions on when one can give antibiotics relative to the time of the slaughter of the animals. In fish, are there requirements that they be antibiotic free at the time they are harvested for market? And is there any monitoring that is done looking at tissues of fish for residual antibiotics?
I can answer that. Yes, there is a safety period where antimicrobials are not provided to the fish. It might be 2 weeks, 3 weeks, or 4 weeks, or more, even depending on the antimicrobial. And I know that in Norway and also in Chile, the regulatory institutions test samples from fish, from fish meat for residual antimicrobials. And also, I understand here in the United States and in Europe and in China, the regulatory agencies also test fish meat for residual antimicrobials. But the sampling is not that extensive. And this is my impression. I have the impression that in the case of Chile or even China or Vietnam, where large amounts of antimicrobials are used, probably the testing is not enough to detect some of the residual antimicrobials. And from the time of, from the point of view of the production, sometimes farmers are obliged to push the limit of the time of use of antimicrobials because they have invested in growing the fish, 1 year, 1.5 years, and they don't want the fish to be sick just when they're going to be sacrificed for marketing. Okay, and I'm pretty sure that there are cases where antimicrobials are used till the end before killing the fish, and they are not detected because the sampling is very spotty.
Thank you.
Mary, I can speak just briefly as far as the United States. There are antimicrobials approved for fish, for fish farming type situations, catfish and salmon primarily. And indeed, they do have withdrawal times established for those. They have to follow, like any other food animal, establish a withdrawal time before that drug can be approved. And if for anybody in the audience that wants to look at some of that information and data available, go to FARAD, FARAD.org. I always have to put a plug in for them because they're based here at NC State. But if you go to www.farad, FARAD, it's really good. You can search on any species, any drug, any animal species, and so forth, and find that sort of information.
Felipe, I just have one more question for you that kind of came to mind. Is there any work done where they use sentinel other fish species outside of the cages used to grow fish as kind of environmental monitors for spread of?
It's very good you asked me that question, because we did a study like 8 years ago with wild fish around the cages of salmon, and we found that wild fish that is used in human consumption in Chile contain in their intestines salmon feed with antimicrobials. Okay, then that is another way that excessive antimicrobial use in agriculture might impact the marine environment, because all the fauna around, are ingesting or are exposed to antimicrobials.
Yeah, super, thank you. Are there any other questions with a real hand or virtual hand? Kind of up, Eleutherios.
Hi, I have a question for Felipe. Felipe, we heard that in Norway, vaccines helped a lot move away from use of antimicrobials. What would be the cost ramifications for a whole industry to move away from antimicrobials? Is that feasible? And what would be the initial cost related to this? Thank you.
Yes, you know, because Chile has the salmon industry in Chile has problems in marketing because this excessive use of antimicrobials. There have been efforts to raise salmon without antimicrobials. And there are 1 or 2 companies of the 20 or something companies that are in Chile that are trying to do that, and they have achieved some success. But and this is very difficult to this is very difficult to study and to ascertain, because the impression is that antimicrobials are used, and they're used in such a large amounts because there are problems with infection control in the raising of fishes. And one of the problems with infection controls, and you saw in one picture I showed you, that the cages are too close in Chile if you compare them with Norway. Also, the cages in Chile are too close to the coast, while in Norway are sometimes 5, 6 miles or 10 miles from the coast. And all those things make the difference in why Norway used less antimicrobials than in Chile. Another important thing is the concentration, you know, of fish per cage. Farmers, to increase productivity, have the tendency to use high concentration of fish in cages in Chile than in Norway. And that also facilitates infection and increases the use of prophylactic antimicrobials. But I think it's possible. In Chile, there are companies that are growing salmon without antimicrobials, and they seem to be economically feasible.
Yeah, super. Thank you. I think we've come up. One more question, Marta, then we'll close after that.
Felipe, thank you for the presentation. Could you also provide a picture of how many of those companies have veterinarian support, or how they are small or big, the sizes? Because I think that that's an important factor on their ability to deal with practices. Yeah.
The companies have veterinary support, and according to Chilean regulations, you know, antimicrobials have to be prescribed by a veterinary. Okay, but in spite of that, you know, antimicrobial use in Chile is excessive, and there are many blind spots, and I think, in the regulatory process that allows that excessive antimicrobials are used. But veterinarians are available to companies; all of them have them, and the Chilean government now, as I told you before, because the marketing problem for this excessive use of antimicrobials, is training now veterinarians in stewardship of antimicrobials. And as you saw in the slide I showed you, it has been a decrease in the use of antimicrobials, but still the amounts that are used are large amounts if you compare them with the amounts used in Norway, for example.
All right, thank you. Thank you, Felipe and Mark. I don't know if we have any other presenters. Anand is still available. So anyhow, I want to thank all of our presenters today, and also the committee members, who I will see all of you tomorrow morning or afternoon, depending where you are. So take care, enjoy the rest of your day and or evening.
Thank you.
So, all right, take care.
Thank you.
Thanks, guys.